can present it.
Okay.
Yeah. Right.
So ethics in paediatric palliative care. For today, let's equate ethics to making decisions, to keep it simple. I have one conflict of interest. I'm an intensivist. Don't normally get invited to palliative care meetings. Very grumpy people, as you can see. So if palliative care is the umbrella, ICU is the snowboard. I may not get invited back. So I'm going to start with my speciality and talk about its evolution, and then a bit about palliative care and how it's kind of become very embedded and crucial for the work we do. So how decisions are made has changed rapidly. And I'm going to use cancer as an example because of this meeting. So in the 1990s, when I started doing ICU, if treatment was non-curative, very few children would be allowed to come into the ICU. If treatment was curative, that decision to admit may be variable. So maybe post-op after a biopsy or a resection, line sepsis. But often if it was a pneumonia, progressive lung disease, post the early bone marrow transplants, ICU would be declined for a child. Boy, have things changed. The concept then was ICU was for children with reversible physiology. We would bring children in, we could get better, could cure. And there really have been massive changes in 20, 30 years. Generally, many children have multiple admissions to ICU, chronic ICU, chronic organ support, that might be long-term ventilation, renal replacement therapy. And this is kind of the world that palliative care has grown up into. So now, the sort of treatments we have, CAR T-cell therapy, gene therapy, precision medicine, low-intensity conditioning for HSCT, which you're aware of, ECMO, very, very broadened out for many children, oncological, non-oncological, prolonged organ support is more frequent, and even to the stage where we have considerations of pluralism in the very determination of death. So that's my pitch that things have really changed. What about pediatric palliative care? Well, it now exists. It didn't exist 30 years ago. And it's really become embedded, certainly in our ICU at Great Ormond Street, from very early oncology origins. So we started having routine ward rounds by the palliative care team on the ICU in the early 2000s, which were incredibly helpful, largely just to nudge us towards, well, should this child have palliative care as it leaves the ICU? But as I've said to you earlier, the complexity of pediatrics now means that many children will come into the ICU well known to palliative care teams, or with diseases that mean they ought to be known to palliative care teams if they're not. So when should pediatric palliative care get involved? Well, some of this is my opinion, but some of it's practical as well. So for instance, at diagnosis, some of the high-risk brain tumors, children with very high-risk oncological diagnosis will meet the palliative care team at diagnosis. I think the key thing for you, and you're well aware of this more than I am, but the idea that you either have palliative care or active treatment really has to go. And it still kind of exists in some small places, different countries, different specialities, and it's a real problem. There needs to be a normalization. I'm really glad to hear that in the first talk, a normalization of ongoing palliative care involvement with the child and family. So do we ask the family if they want to meet the cardiologist? No. But we still have to ask them whether they want to meet the palliative care team. It's a terrible question, isn't it? And I think so much of our problems in this area are with language. Would you like to meet the team who look after you if you're going to die? Well, all that is wrong. Palliative care look after children who survive, thrive, get handed over to adult services. Children with life-limiting conditions or life-threatening conditions are the remit of pediatric palliative care. You can see that from an AAP diagnosis here. So in some ways, should every child with a life-limiting condition or a life-threatening condition meet palliative care? Or should there be a consideration whether palliative care should add something to that child's current multidisciplinary care? And I think the answer to that is there should be a consideration. Obviously, palliative care teams are not limitlessly resourced. So there's an awful lot of children who fit that diagnosis where the answer will be not yet or not at the moment, but there should certainly be a consideration. And the biggest error I tend to see is not involving palliative care. So I'm talking about ethics. Ethics is very multifactorial. You could have different definitions, different ways of thinking about it. But we're going to stick today decision-making. Ethics being making the right decision, trying to get things correct for the child. So what sort of decisions are we talking about where pediatric palliative care, oncology, maybe ICU get involved? Well, there are some generic ones, which might be withdrawal of life-sustaining treatment. That might be ventilation. It might be DNA CPR. or withholding a life-sustaining treatment like renal replacement therapy, or more specific in the oncological sphere, chemotherapy, radiotherapy, immunomodulation. So the decisions can be about different things, but how are those decisions made? I'd like you to just think to your own practice, not sitting here in a room full of people who agree with your views and think the same way, but actually back to your hospital and actually how these decisions are really made. And I would argue generally they're made by specialist physicians and surgeons. There may be a medical MDT component. Even with a national MDT in the UK, we have this kind of national MDT set up with oncology where difficult cases are discussed. Will the palliative care specialists get involved with those complex decisions about limiting treatment, deciding about stuff? Sometimes, if the child's very well known to them, but often not otherwise. The intensivist, many decisions happen about whether ICU should be offered to a family and child without the intensivist being involved, which is always a bit of a problem. And then do we really involve the rest of our multidisciplinary team? Are the ward nurses who know the child really well if the child's an inpatient involved? Are faith leaders brought in? Allied health professionals? And then finally, do we make these decisions with the family, or do we make the decisions and tell the family what those decisions are? So do we have truly family-centered decision-making or a clinical decision and then decide whether the family want to accept it or not? I'm just challenging you to think about your own practice there. So here's a document from my country. I hate this document, so I'll bring it up anyway. NHS England, which has just been got rid of yesterday, hot off the press there. This is about shared decision making and national guidance about this. And it suggests that clinicians bring treatment options and patients bring their beliefs, lifestyle, and values. And normally I pause here and go interactive, but it doesn't really work so well on Zoom. So, any problems with that? Well, sure there are, because clinicians have values. You all have values. You have decision-making values, you might have religious beliefs, you might have views on how you think things should be working in your hospital. But here's something that always surprises people. Whether you have CPR at the end of life in European adult ICU depends on the consultant's religion. So Charlie Sprung did this a long time ago, the Ethica Study Group. If you are having end-of-life care in ICU in Europe, if your consultant is a Muslim or a Catholic, you're more likely to get CPR than if your consultant is a Protestant or an atheist, independent of the country you're in, independent of other things, including the patient's religion and other stuff. I think that's quite a surprise, but it's a nice example that we have values that we bring to our clinical practice. And of course, the other argument is patients bring facts too. Increasingly, the world of Dr. Google, but with rare diseases, which I spend my life involved with, patient groups will often have more information on the latest information about research and other stuff than certainly someone who's a generalist like me in the ICU will have. So patients bring facts as well, and we have to bring these things together to help with this truly shared decision making. So here you go. Here's an old man reflecting. Things I have seen got wrong in this space. Well, 20, 30 years ago, intensivists declining patients' admissions because palliative care were involved. Clearly, that's wrong. Exuberant oncologists telling the family that the oxygen going from 90 to 80% when the ventilator pressures go up in the ICU is good progress, equally problematic. ICU people telling families continuing is futile, patients demanding renal replacement therapy in a dying child supported by a specialist, crazy. An experimental chemo that colleagues in the US have said we wouldn't try, offered for a couple of months on a child in our unit. So, really strange decisions that sometimes happen in this difficult sphere about complexity, end-of-life care, palliative care, and oncological treatments. Things I've seen got right. So time-limited trial, I still think this is a sensible thing to do. Of compassionate chemotherapy following an ethics review, with all the team together agreeing to do this with a review at the right time. Transfer home for compassionate extubation. We do that frequently now, together with ICU nurses, palliative care and oncology nurses. So at end of life, when you're going to stop a ventilator and everyone agrees that's the right thing to do, you can do this in the child's home and bedroom if that's the right thing for that child and family. And a horse brought into a hospital for a dying child. The child's horse is very important to it. And that's the sort of thing, if you're creative, you can bring things together. That horse came to the chapel downstairs in the hospital. What about these decisions? Is there any guidance or frameworks? Well, yeah, we have in the UK a national guidance, which I'm one of the authors for, probably due for revision quite soon, but how you make decisions to limit treatment in life-limiting and life-threatening conditions, the very conditions when palliative care ought to be involved with children's care. And so this is an ethics guidance, but also a legal guidance. So for different countries, the legal stuff will be very different, as you heard in the first talk, but the ethics is fairly generic, right? The way we thought through this, end of life care, there's much more palliative care involved in that, even in ICUs. So palliative care teams really are part of end of life care within the ICUs now, although the lead team of that remains the ICU team. Palliative care will come and give options. They may talk about different treatment possibilities. And the important thing there is many of the children involved will have palliative care involved for many years, and they're a huge support to the family. Organ donation has become routine, and the 5 categories have been changed. You don't need to know that much of that detail, but the important bit, a new 3rd category came in, which got us in real hot water in America. They hated this, got lots of complaints. This is where a competent child consents to palliative care supported by the clinicians and parents. We were like, well, that's no biggie at all, but we had lots of letters from the Middle East not happy with that at all. So this is kind of, if you put it on its head, this means the child that thinks palliative care is the right thing, having been through and experienced an illness over many years, and the clinicians and parents agree, are you going to say that's not okay? Strange. Okay, and the axioms about decision-making, I think, are important, and they're derived from consideration of ethics and legal principles, which are set out in the document, and I haven't got time to go through them all for you today. But they're related to decision-making in general and circumstances when treatment might be withheld or withdrawn. So remember, it's not all about switching things off. You might decide not to give something as well. The key thing about this is there needs to be open, timely communication and mutual respect, a sharing of values and views together with the family and child, ideally, if the child is able to take part in decision-making. Any decisions made must be informed by the facts, but also freely made. Any disagreement is ideally resolved by consensus and usually is with time. And of course, in the UK, as in most other countries in the world, parents have ethical and legal authority unless, well, the question here is the best interest versus harm threshold about state intervention in the child's care. So if parents want to do something that you think is harmful to the child, then that's a challenge in terms of, well, that's not okay, and how there are systems to sort that out. But what if they want to do something you don't think is in the child's best interests? There's a different level, something that isn't harmful specifically, but you think there may be a better treatment available or something might be a better course. Child's wishes are important, mediation can be attempted, and legal intervention can be there. And at this stage, I think it's worth thinking about why we do the job we do. The Hastings Centre is a nice ethics think tank in the US, but it came up with this really nice document some time ago. And it's like the thing you're not allowed to say when you first apply to be a doctor or to be a nurse or to go, you're not meant to say, I want to help people. But this is why we do medicine. We want to prevent disease, relieve suffering, care for the ill patient, and avoid premature death. It's worth just reflecting on that. That's the goals of palliative care, of intensive care, of all medicine. Just worth focusing on that. And into this comes a term that I think you'll agree ought to be banned. And sometimes we see this bandied about. The term futility is incredibly problematic for most families when they hear it. It's very loaded and often it's inaccurate. So if a family say to me, we want to carry on the ventilation to keep my child alive a bit longer, I can't say that's futile because carrying on the ventilation will do exactly that. I may think it's not the right decision. So, there may be things we can use in different language, but the language of medicine, this is the point I'm making, is so important. And I think palliative care teams are super good at this, and the rest of us are kind of catching up a bit. But, that term is now banned according to all our major European and US critical care bodies, unless something truly is futile, like a head transplant. You can't do that. So physiological futility should be the only thing that's used for, not value differences. So onto these decisions again. Well, I've said already a bit about stopping, starting, or limiting. What sort of things? Well, ventilation, chemotherapy, parenteral nutrition, or CPR. Into this world, Lorna's going to speak to you later, and this is probably what I think the best bit of work she's done. And it shows the prevalence of what are called life-limiting conditions in England by major diagnostic category. And the important thing here is they're going up across the board. all diagnostic categories, children living with a condition they're expected to die at some stage during their life from, not necessarily during childhood, is increasing. But on the right, you see these conditions are in more deprived more deprived socioeconomic groups and different ethnic groups as well. And our services have not developed well enough to look after people who are most affected by this. So the important thing is now 2/3 of admissions to UK children's ICU are for children with a life-limiting condition. That's a complete transformation in 20 years. Recurrent admissions are more common, but we do more and more really expensive treatment. So SMA treatment with NIV, so millions of pounds on a single child. And also we have parents who want to carry on long-term ventilation for patients who we think fit the neurological criteria for death. So there's huge amounts of changes. And certainly in our country, we can't stop the ventilator without parents' agreement, without the court getting involved. So these are big changes in what we do. And I think you can see that the role of palliative care in that setup is much more important than, say, 30 years ago, with children who came in with meningococcal disease and survived or died and went home. Now children have this need for ongoing support during recurrent ICU admissions, their life at home, times in hospital. And so children living with the terms will be complexity, often neurodisability, other conditions. And that's something that palliative care are super good at. That link between tertiary hospital, secondary hospital, general practice, and the parent's normal home, where they're living hopefully with the child more than being in hospital. That link is something that palliative care do better than anybody else. What about decision support? Well, it's not just about ethics. There are other groups involved. We do have chaplaincy, external faith support. We're lucky in our hospital, and I think anywhere you work, if parents have a strong religious belief, bringing in support for that, whether it's chaplaincy or external religious people, can be really helpful. Ethics and mediation can be helpful, particularly with the most difficult decisions. And we have a process in our hospital where we have parents come into the ethics meeting, and children, if they're able and old enough, they'll come to the ethics meeting to discuss their values and their thoughts. Second opinions are becoming quite hot at the moment, a couple of frameworks about that. So something that lets parents and children know that the decision being made is reasonable, that other centres might have or not have different things they might try. I wouldn't recommend Facebook, I'm afraid, and the court occasionally might be required. But heading towards the end, so the key thing here, there's Immanuel Kant, German famous philosopher, looking miserable as ever. The key thing is that doing things to versus for the child is not allowed. We must do our treatments for the child. And that's sometimes where this tension about parents' decision-making, clinicians' decision-making, and where you can get into kind of, well, is it reasonable to do this? If you don't think it's for the child, then there is a problem there. Kant said, never treat a human being only as a means to an end. And that end includes the parent's preference. So you must treat the child in the way you think is the right thing to do. It is your job. In the UK, for sure, parents that own their children, there is best interests and welfare, and the parental rights and responsibilities have to be exercised in the child's best interest too. With this, we do have some, you may have seen the recent disagreements in the courts and the cases like Charlie Gard, Alfie Evans, and we had a national review about this, looking at disagreements in the care of critical children. It's worth a look through this. There's a good literature review about this. But as I said earlier on, one of the main findings is language. Language has to be improved. And I think that's something we can all get better. If you're interested in the ethics and law of this area, there's a paper here, it's free on the interweb thingy. And it's a justification of why the harm threshold used in the US, for instance, is problematic compared to trying to operate in the child's best interest, which is kind of the UK's bringing into the Children Act the UN Convention of the Rights of the Child, which tells us the child's best interests are really what we ought to be aiming for. I won't spend too much time going into the law because I don't understand it half the time, but this paper will go through the ethics and the law of that if you're interested in reading further. So how should we decide to treat the child, harm versus best interest in disagreement cases? What about ethics? Well, really, if you're looking after complex situations, particularly with paediatric ethics, I do think there is a need for ethics advice and support. I don't think there is anything like pediatric palliative care ethics or pediatric intensive care ethics. There's just ethics. And when you're looking after children, I think there are unique things about that role of the parents, the family, and the child themselves as they get older in decision making. And so we have, one of our most frequent oncological ethics referrals is about complex surgery and maybe amputations for different things for children with oncological disease. And that can be a real challenging situation, which some of you will be aware of. But the key thing there is the ethical advice is to support the clinicians, the child, and the family. And we spend a lot of time with them going through how we ought to make these decisions. But there's some basic things here about how you might, the references in there. It's an archives disease of childhood. If you look up my name, you can find the paper. It's free on the internet. But this is about how ethics committees ought to work. And there really ought to be an ethics advisory body for anyone looking after complex oncological patients, I think. Just to go in a complete different direction, one thing that's also important is the difference between different professionals. So we did a bit of work surveying European professionals about end-of-life decisions and when they're made. And you can see that, the nurses are, as you would not be too surprised to find out, slightly more worried about timing of end-of-life decisions being too late versus medical practitioners around Europe. And the other thing that's kind of important when I talked about the difficulties of these cases, as medicine gets more complex, the way we make decisions is super important. And when you've heard about some of the disagreement cases, we actually looked at what the ICU trainees who are the intensivists of the future thought about these difficult high-profile cases that get in the press. And they are incredibly worried about them, as you would expect. And so they feel unprepared and anxious about these things. And I think one of the key things that the Nuffield Council really wanted to highlight was the involvement of paediatric palliative care in these cases is very important. Having said that, most of the very difficult high-profile cases did have paediatric palliative care involved. But I think some of the language skills, some of the relationship building that paediatric palliative care are very, very good at can certainly rub off on other professionals. And that's something that I thought might be able to mitigate this. The reason these things are important, I'm going to leave you with this. So if you are working in a high intense specialty, the chance of burnout due to a number of things, which might be hard rotas, but actually recurrent difficult decisions that are being made, the impact of very sick children and trying to work out what to do, burnout in doctors doubles the chances of patient safety problems, particularly for those working A&E or intensive care. And this is the worry I have for the future. I think where, I think some of the things that need to happen around Europe that will probably protect against this to some extent are the involvement of paediatric palliative care and training and discussions in language and how we talk with families. So that's kind of where I'm going to finish. I think the main thing I wanted to leave you with is that paediatric palliative care is of increasing importance, not just in oncology, but throughout pediatrics. It really needs to be normalized in terms of the interaction with the family over years. And we have families who sometimes have pediatric palliative care involved, and then the pediatric palliative care team will step away for a bit. Then a few years later, if the child's situation gets a little bit worse, they need more support, they will come back in. And that also, the interaction with palliative care, with hospices for various families is unbelievably important. When you have up to 2/3 of your patients having life-threatening conditions, that important working relationship between acute specialists and the paediatric palliative care team are very important. So the end of my pitch is ethics support is very important. Paediatric palliative care is very important, and they almost have a massive uplift in funding throughout Europe.